Principles of prescribing. So a medication review or medication reconciliation should occur at each transaction. I know most of the literature says once a year, but for us it should be at every transaction, every appointment, to ensure the appropriate medication and doses are continued and unnecessary ones are discontinued, and also to ensure that the patient is actually taking the medication as prescribed, that they actually understand how to take it as prescribed. To discard medications that have been discontinued or doses changed to prevent accidentally taking incorrect or duplicate doses. We have patients that have received their refills and they still have older medications, and they're all when they bring them, you see that they have multiple vials of the same medication. Patients should be encouraged to carry a complete, up-to-date list of all their medications, and as we said before, this should include over-the-counter medications and supplements. For new medication prescriptions, we should start at the lowest dose and increase slowly as indicated or as required. Principles of prescribing for older adults, the basics. Again, start low and go slow. Titrate up, which is increasing the dose slowly as tolerated by the patient. Avoid starting 2 medications at the same time, because if there's an adverse reaction, we will not know which of the medications is contributing to that adverse reaction. Avoid using combination formula medications for 2 different medications in 1 tablet, for the same reason as I said before. If there's an adverse reaction, we will not know which of the medications in that combination is causing the issue.
American Society of Health System Pharmacists provided recommendation on reducing unnecessary treatments, preventing adverse events, as well enhancing patient safety. As just Dr. Lawrence mentioned, what they recommend is not to initiate any medication to treat symptoms, adverse events, or side effects without trying to find the cause of it. Not to prescribe new medications to patients, especially if they're taking 5 or more medications, without a comprehensive review. Not to continue medication just solely based on because patients was taking it. And not to prescribe or restart medication at discharge that patients were on prior to admission without verifying that those medications are needed. And use only metric measures when prescribing liquid medications. In 2023, the American Geriatric Society updated Beers criteria which focuses specifically on treatments for adults older than 65. There are 5 categories that medications are divided in the Beers criteria: for potentially inappropriate medication for older adults, potentially inappropriate medication to avoid, medication to be used with considerable caution, medication combination that may lead to harmful effects, and list of medication that should be avoided or dosed differently for those patients with poor renal function. This is an example of what Beers criteria included. For example, for opioids, they added medication because they can exacerbate delirium. Additionally, they added anticholinergic medications to avoid in patients with history of fall or fracture. They also have another category as potentially inappropriate to use with caution. One of the classes included in that list are sodium glucose cotransporter 2 inhibitors, increased risk of urinary tract infection, and diabetic ketoacidosis. Additionally, they added ticagrelor due to the risk of major bleeding, and prasugrel consider using a lower dose at 75 for those patients who are 75 or older, a dose of 5 milligrams. Next category in Beers criteria is potentially inappropriate to use. One of the medications there is aspirin. It was moved from caution to potentially inappropriate because it recommended to avoid initiation for primary prevention. Consider deprescribing if patient is already taking it. Warfarin was added to the list. The recommendation is avoid starting it as initial therapy for non-valvular AFib or VTE, and use alternative such as DOACs if possible. Rivaroxaban was also added to the list. High risk of major gastrointestinal bleeding in older adults than other DOACs. Sulfonylureas was expanded to all of them. Avoid use unless there is a substantial barriers. And PPIs, proton pump inhibitors, added pneumonia and gastrointestinal malignancy to the risk. Screening tool to start to alert providers the right treatment, or also called START. This tool is extremely useful for providers as a criteria to start the treatment. A recommendation is to be watchful for medication started at the younger age and adjust if needed. Avoid adding medications to treat side effects. Do not automatically increase the dose, as set an end date and objective criteria to determine when is medication considered as a failure or success of the treatment. As we said, risk factors for adverse medication reactions really increase with patients taking more medications, having 6 or more concurrent chronic health conditions placing patients at the risk of side effects, being required to take 9 or more medications, also placing patients at the risk, and taking 12 or more doses of medications daily increase the risk of ADRs and placing patients at the higher risk of non-adherent. Prior adverse medication events, patients, if they had any side effects prior to taking the medication, need to be carefully reviewed. Additionally, low body weight or low BMI patients with low BMI can alter drug distribution and metabolism, especially of lipophilic drugs. Patients 65 and older, advanced age is associated with decreased hepatic metabolism and renal clearance, leading to prolonged drug half-life, increased sensitivity, and also may lead to cognitive decline and functional impairment. Let's continue talking about adverse medication events. The subset of AME and adverse medication reactions refers specifically to the harm caused by a medication when it's taken correctly at the recommended dose. Examples include allergic reaction, for example, to the penicillin, or gastrointestinal bleeding from aspirin. The most common types of AME is unintentional overdose. It may lead to adverse medication reactions. Risk increases with the number of medication increased, and common drugs involved are cardiovascular. For example, antihypertensive medications, anticoagulants, and statins are prone to interactions affecting blood pressure, bleeding risk, as well as psychotropic medications. Antidepressants, antipsychotics, and sedatives, they may affect, they may interact with other CNS medications, and or serotonergic drugs, increasing the risk of serious side effects like serotonin syndrome. Let's talk about common medication disease interactions. Drug disease interactions refer on how certain medical conditions or medications and diseases can alter the drug's response to the medications. For example, dementia may increase the sensitivity or reactions to medication with central nervous activities. Obesity may also alter distribution of lipophilic medications, as we previously said, medication that dissolves in fat, lipid, and oil. Excess abdominal fluids in ascites alter the distribution of water-soluble drugs, such as diuretics, antibiotics, potentially reducing their effectiveness. And renal or liver hepatic dysfunction may decrease excretion, elimination of the medications.
As Dr. Roitman mentioned before, this is a picture of ascites. This is not somebody that's just overweight. And if a person is collecting fluid in their abdomen, it will interrupt or affect the way that fat-soluble vitamins or fat-soluble medications are dissolved or absorbed or metabolized. Over-the-counter medications and potential medication interaction, especially with prescription medications. A lot of persons think because it's over-the-counter, it's safe and more is better, but it's never better. You should definitely stick to the dosage that's on the bottle. Some medications that could interact with prescription medications, such as non-steroidal anti-inflammatory drugs, could interact with prescription lithium and increase serum lithium concentrations. Warfarin, which is often prescribed as a blood thinner, can increase the risk of bleeding. Drug disease states interactions, chronic kidney disease, reflux, hypertension, and heart failure. Antihistamines, which we take for allergy relief, can cause anticholinergic effects. Antacids, which we take for reflux again or for upset stomach, can also interact with histamine 2 receptor antagonists and may require dose adjustment in patients with renal insufficiency. Antispasmodics can have anticholinergic effects also, and cognitive dysfunction, disrupted sleep, confusion, cause hallucinations and delirium, and decrease vision and motor reflexes, and may increase the risk of falls. Pseudoephedrine can exacerbate insomnia and agitation, proarrhythmias, seizure, and hallucinations. Drug disease states interactions with hypertension, benign prostate hyperplasia. Dextromethorphan can interact with morphine derivative and can result in increased dizziness and sedation. And laxatives, which sometimes are abused for different reasons, overuse of laxative may cause electrophilic disruption because you're excreting more than you should be because of the use of the laxatives, or result in dehydration. Both of these could be proarrhythmic and can contribute to lithium toxicity. Dietary supplements and potential medication interactions. Dietary supplements and common uses such as ginseng, which are used sometimes for memory and cognition enhancement, this is non-prescription use, can interact with MAOIs and cause headaches, tremors, mania-like symptoms. Warfarin, again, which we mentioned before, which is a blood thinner, can decrease serum warfarin concentrations. So it actually causes the amount of warfarin, even what you're taking, not to be used or absorbed by the body. St. John's wort, which a lot of people think is a safe medication for antidepressant or mood enhancer, so it's not a prescription, and a lot of people are taking, can cause some of the other side effects on the other side. SSRI, drowsiness, potentiate serotonin, and increased risk for serotonin syndrome. Tryptophans potentiate serotonin and increases risk for serotonin syndrome. And as the list states, statins, which a lot of people are also taking to control their cholesterol, the dosage may be decreased if it's taken with St. John's wort. Again, warfarin, anticonvulsants, which may be taken for epilepsy, for seizures, may decrease the effect of the prescription medication that they may also be taking at the same time. Kava, which a lot of people are taking for insomnia and anxiety, black cohosh, ginkgo biloba, again for cognition, ginger, and for acid reflux. It actually is could cause increased bleeding, especially if taken concurrently with warfarin. So the side effects of ginger is also as a blood thinner. Garlic, which a lot of people take to control their hypertension, cardiovascular support, could interact with if you're also taking aspirin and increase bleeding time, the risk of increased bleeding, and clopidogrel and warfarin also if you're taking those as a blood thinner.
Next few slides list medication to be carefully considered before use in older population. First one is first-generation antihistamines such as diphenhydramine. It increases anticholinergic effects such as dry mouth, confusion, constipation, dizziness, palpitation, and hypertension. COX non-selective NSAIDs, ketorolac, with chronic use can increase risk of GI bleeding, especially for those people who are older than 75, increase blood pressure, and cause kidney injury. PPI such as omeprazole, esomeprazole, pantoprazole, a long-term use, which defined as 8 weeks and more, may increase risk of C. diff as well as osteoporosis and fracture. Metoclopramide, short or long-term use can lead to extrapyramidal symptoms. Digoxin decreases renal function and may lead to increased digoxin toxicity such as nausea, vomiting, altered color perception, malaise, and arrhythmia. Benzodiazepines, the increased risk of cognitive impairments, delirium, and falls need to be carefully considered before prescribing to older population. Other antidepressants such as amitriptyline, They are highly sedative. They also cause orthostatic hypotension. Non-benzodiazepams and benzodiazepam receptors agonists hypnotics such as zolpidem. They increase risk of delirium, cognitive impairment, motor vehicle accidents, and minimal improvements actually in sleep latency and duration in the elder population. Short-acting insulins with or without longer-acting basal insulin regimens, they increase risk of hypoglycemia events without improvements in long-standing hypoglycemia. And glipirides and glipimerides, they cause severe prolonged hypoglycemia.
Principles of prescribing. So as I said before, at least annually encourage our patients and or their caregivers to bring all medications prescribed, over-the-counter, and supplements in to their appointments for our review. Medication reconciliation should occur at every patient visit by each healthcare provider that is involved in the patient's care. Ask about side effects and medication to medication and also medication to illness interactions. If you don't ask, the patient may not remember to mention it or may not be aware that it's something that they should have reported. Look for and eliminate duplicate therapies or pharmacological effect. Eliminate unnecessary medication and simplify dosing regimens.